I'm Dan from Correct Osteo Clinic, and today I wanted to talk to you about the shoulder complex. Now, you'll see after today probably why it's called the shoulder complex, because there's so many structures that are involved in the shoulder and with movement of the shoulder, and with so many structures that are involved, it means that the likelihood of them going wrong is higher as well. So let's talk about some anatomy of the shoulder. So I've got a little model here of the shoulder joint. Okay, so you can see the different bones that are involved in the shoulder. So you've got your humerus here, or people call it their funny bone, that goes up. You can see the head of the humerus here, where it actually attaches into the shoulder joint itself. This acetabula here, this socket here basically. So this socket is made up of different bones. So you've got what's called your acromion here, so that's the very top of it. You've got a little bone that sticks right out of the front here called your coracoid process. You've also got your clavicle. Other people know this as their collarbone, and you've also got your scapula. So people call this their shoulder blade. That is also known as. So different movements of the shoulder. You've got, because of all these bones and it's such a shallow socket, you've got quite a lot of degrees of movement of the shoulder joint. Okay, so you've got more in that than you would have the hip. The hip socket is a much deeper socket than the shoulder joint is. This is quite a shallow socket. So that way you've got, like I said, more mobility of the shoulder. You've got what's called flexion, so where it comes forward and up. You've got extension, where it goes back and up. You've got abduction, or abduction, also known as. So like getting abducted by aliens, it sort of takes it away from the body. And you've also got adduction, adduction, where you add it towards the body and it also comes across as well. You've also got other movements such as external rotation and internal rotation as well. So where your humerus, this bone here, will internally rotate or externally rotate. There's certain muscles that are responsible for solely just those movements, really. There's a big complex of muscles that are involved in these movements. They're called your rotator cuffs. There are also other muscles that do get involved, like the latissimus dorsi, pectoralis major, that sort of thing. But the main ones are things like that run down the back of the scapula, that shoulder blade. So they're more in this location here. They run down here, such as your teres minor, your teres major. You've also got infraspinatus, supraspinatus in this area as well. So the ones that are, apart from the teres major, teres minor, infraspinatus, supraspinatus, those ones are mainly responsible for the external rotation. So from there to there, that movement, or from there to there, that movement. And then you've got ones that are involved for internal rotation. So again, it's like from that movement to that movement, or from that movement to that movement. Okay, so those ones are called your subscapularis. So the ones this one sits on the inside of the shoulder blade. Okay, this scapula. So obviously you've got your scapula that wings along the back here against the ribs. However, you've got a muscle that sits underneath the shoulder blade, in between the actual scapula and the ribs, that it glides along. Okay, then that's called your subscapularis. This is a major one responsible for internal rotation. There's one that sits around the back here, attaches onto the outside here of the scapula, and then onto the inside of the humerus. That's called your teres major. You've also got your pectoralis major as well. So other people know it as their chest muscles, the one that when you go to the gym you're doing things like chest press, that sort of thing, to get this muscle sort of healthy, bigger, stronger, that side of things. But that will come across the chest here and attach onto the humerus. And also there's other ones that come into play as well, like latissimus dorsi. That muscle, a big powerful muscle that goes down the side and of your back here, okay, and it comes up here. And people like you might see in certain bodybuilders or people with like good muscle mass with low body fat, they can do what's called a lat spread as well, so they can actually wing their lats quite a lot, and you'll see these muscles stick out to the side here as well. You've also got things that will help with like certain movements like abduction. So like I said earlier, that supraspinatus, it sits in this fossa here, so this sort of groove of the scapula. So if we look at the back of it, you've got what's called the spine of your scapula, and then you've got this groove up the top, and then just through there, I don't know if you can see, there's a little hole just in there. Okay, so that's the subacromial space. So it sits into this space here, and it will go through that hole and come out the other side. If you can see my finger, it will come out the other side and then attach onto the humerus. That's responsible for the first 15 degrees of abduction, and then it's what's called your deltoid, so these big powerful muscles that sit over the shoulder here. They are then responsible for going into a lot more, to 90 degrees, so from that 15 to 90 degrees of abduction. And then you've got the big massive powerful muscle like your trapezius and what's called your serratus anterior, that will then go even further, so above 90 degrees. They come into play with those sort of movements. But the scapula itself is very important that it has to wing. So when it gets to 90 degrees, so your humerus here, it can come out and in. When that gets to 90 degrees, to get more than that, your scapula has to move. It has to glide along the back. And some people get a dysfunction in that movement. It's like they can get something called scapular dyskinesia, where it doesn't move, or it judders. It doesn't move as fluently as well. That can be a problem with what's called the serratus anterior muscle. That is responsible for that movement of the scapula. So that's quite a bit of movements there of just the shoulder joint itself and the scapula. But you've also got other things that are responsible in the shoulder as well, such as your ligaments that are for stability. So you've got all different ligaments here. As you can see, these sort of like very, that they are quite flexible on this model here. However, they're very tough and fibrous tissues, and all of these ligaments, you can see how many there are that surrounding the actual shoulder joint itself. These sort of band-like structures here, they're all responsible for stability of the shoulder. You know, so there's quite a lot you can see around the actual shoulder joint, and it's so important, like I said, because you've got a shallow socket, or the shoulder is a shallow socket. It is very important that it stays stable as well, because it can dislocate, or what we call sublux. So the most common dislocation of the shoulder joint, the glenohumeral joint that we call it, so the glenoid cavity, and the humerus, the glenohumeral joint. Okay, so where they come together, it can go forward. That's the most common dislocation and where it happens. So where this bone here, it will go forward and sort of down, so it comes forward and down like so. That is the most common dislocation of the shoulder joint. But also you can get obviously tears and sprains and so on of the different ligaments. I mean, when you're getting force transit up through the shoulder joint itself, it's normally when you fall onto outstretched arms, the force starts to dissipate through the arm itself, so it will then come through the arm, and the shock will come all the way up, and normally is taken by the clavicle, and unfortunately that is an area for dislocation and fracture as well when falling onto like things like an outstretched arm. So this bone here, called your collarbone, that is the one that's commonly sort of fractured or even dislocated. But even there, look, you can see the ligaments there that surrounds what's called the AC joint. as well. So the acromion clavicular joint. So acromion, this little bone that I said earlier, and the clavicle where they meet, that's a little joint there as well. Talking about the actual shoulder joint, you've got a capsule that will surround it, and one thing that you might be aware of already, that's a common disorder that we see, is frozen shoulder. It's also known as adhesive capsulitis. Unfortunately, it can take up to 2 years to get better, really. So when I say get better, sometimes people don't make a full recovery after frozen shoulder. However, they can get more movement back, reduce some pain, and so on like that. There's 3 stages of frozen shoulder. There's freezing, frozen, and thawing. So the different stages, the frozen stage is 6 to 9 months. So the freezing, I think I said freezing stage. The frozen stage is 4 to 12 months, and the thawing stage can be anywhere between 6 months to 2 years. The reasons why you get sort of frozen shoulder, there's different conditions that can cause it. So actual trauma to the shoulder joint itself, or maybe surgery. Things like diabetes can increase the risk of it, heart disease, Parkinson's disease, even Dupuytren's contracture. So that's a contracture of the sheath that surrounds the sort of tendons and so on. You'll normally see it in the hands. And that you'll get like what's called like a finger like that, really. Okay, so it's like a contracture of the sheath that goes into the finger, but that can also be a cause of it as well. I think that's so diabetes, Parkinson's, Dupuytren's contracture. You've got so I've probably mentioned a few earlier that will increase if it's heart disease, like I said earlier, that will increase the risk of those frozen shoulders. You've also got what's called like bursas. So you've got like little fluid-filled sacs that are all around the actual joint itself. These are like buffers, so they allow friction of different structures over others. So they're located all around the actual shoulder joint as well. But yeah, it's called, when you get an inflammation of these little fluid-filled sacs, maybe from over friction, overuse and so on, sometimes even too much compression as well, can cause bursitis. So a very common one is subacromial bursitis. Again, that bone that we mentioned earlier, just underneath it, in that space that we talked about, that muscle that the muscle goes through. Unfortunately, it's a bit of a bad design of the shoulder, so when you go into that abduction, so when you go into that movement there, it can compress this structure here and make that a little bit shallower, a little bit more narrow, and obviously where the supraspinatus, or that muscle, will run through there, you've also got a bursa that sits in there as well to allow that movement. And allow less friction in, and that can become quite irritated as well, and that's called subacromial bursitis. Also, while we're on that subject, you can also get in that same area impingement syndrome. So just like I explained, when that space gets more narrow, it can impinge obviously the structures that pass through it, such as the supraspinatus as well. You can obviously get what's called arthritis of the shoulder, so things like osteoarthritis, rheumatoid arthritis, that sort of thing. But osteoarthritis is like normally a disrepair of the joint itself, so the actual cartilage starts to get worn down and broken down, and you're not going to get that recovery from that, as in that repairing process again. Once it's sort of worn down, you can't get that back, unfortunately. So you can get what's called like osteoarthritis. Normally comes around sort of after 40s, 50s, 60s, overuse, that sort of thing, or even underuse of the shoulder as well can affect the cartilage output. So I definitely want to make sure you're using the joint a good amount, but not too much as well. You're stuck in that sort of problem there. You've got what's called you can have what's called a labral tear. So the actual cartilage, the tissue that sits in the joint itself, that can be torn. Unfortunately, with like quick movements, such as like baseball throwers, that sort of thing, those big massive rotation and quick movements, that can tear that tissue and cause a tear there. So you get like a clicking, a clunking of the shoulder, normally very painful as well. So that's another problem that can go wrong. A big muscle that a lot of patients take into consideration that can cause things like shoulder pain is the bicep as well. So the bicep, it will actually run, one of the heads will actually run up quite far into the actual joint itself as well, and that can actually attach onto the labrum, the tissue that we just talked about, that can actually tear. So when there's obviously too much strain and so on going on there, or if you get something called tendinopathy, where is either a problem with the collagen or the actual fibers itself of the tendon, or the inflammation of that tendon, you can also get that shoulder pain, that pain located around the shoulder, even just from the bicep. Even though that seems a bit further down the arm, it can give you pain up into the actual shoulder joint itself. You can get another thing like what's called C-spine referral. So you've obviously got nerves that come out of the cervical spine, and so that's the neck, the spine of the neck. Okay, so a lot of nerves will come out of there. If you just give me a sec, I'll show you. So we've got this here. As you can see, the cervical spine is in this area here where your skull sits on top of it, and then you've got all these nerves, these structures that will pass out of the cervical spine as well. These will run, they go into a plexus called your brachial plexus, and they a lot of those nerves are responsible for going over the shoulder, around the shoulder, and down the arm to supply a lot of the muscles of the hand, the forearm, the wrist, the bicep as well, triceps, all those sort of areas, even the muscles of the shoulder that we talked about. When there's obviously a problem there or a disorder that can affect either the spine itself, that can then also have a knock-on effect of the nerves. And I've spoke to you before in previous videos about what I call the garden hose effect. If a nerve is just like a garden hose, if it gets compressed like a garden hose would, it would affect the obviously supply that affects the rest of the hose. So it's the same thing in nerves of the neck. If they get if you have a problem with those, they can then start affecting the nerves and give what's called radicular pain or radiculopathy around the actual shoulder region itself. You can also get what's called visceral referral. So there's certain organs, I know I've talked about this in previous videos. I'm trying to sort of speed up because it's getting on a little bit now. But there's certain organs that can actually refer pain to the shoulder, even though you think the organs will sit into the abdomen sort of area. They can also give pain obviously around that area there where they sit, but they can refer pain into the shoulder regions as well. The right shoulder would be things like liver and gallbladder. Left shoulder would be things like cardiac referral, so or respiratory referral as well, so from the lungs, from the heart, that sort of thing, even from the diaphragm, so the big massive respiratory muscle that very important there. So these are things that can refer to the shoulder. Kidneys can even refer to the shoulder as well. So yeah, it's a lot to take into consideration of the shoulder. It's a big massive complex. There's a lot of structures that are involved in it. Hopefully if I've explained those structures a little bit easier, a little bit better to you, for you to understand a bit easier today, and hopefully I haven't banged on a lot or too much. I know this is getting long, this video, but hopefully that makes it a little bit easier to understand and what we look out for and what we can try and help with. So I hope you have a good day. Thank you.